I would just like to, my name is Rosli, I would like to invite my co-chairperson, Ho An Bin, Professor Tan Hui Chim, Frankie Tam, Purik Surun Kuchapon, Tran Hoa, Nguyen Kek Tai, Lee Kao Feng Dui, if I pronounce them right. Sorry. Okay, so we are going to have a 15 minutes case presentation, and hopefully if we have time we can discuss after each case. So I'll just like to call Dr. Pham Nhat Minh, who is going to present on case number 5, LMS CTO and double-calcified lesions. Stop or go ahead.
So, thank you, Mr. Chairman, my colleagues and my friends. So we are very happy to be here today in a very prospective and very fruitful conference today. And I hope that you enjoy the conference. So I may present a case which is really represented our clinical practice every day. And I think in Vietnam right now, we do quite a lot of complex cases, and in the condition of sometimes we did not very limited resources, and I think that the number of the complex cases doing in Vietnam right now, it may be from 20 to 30%, and with this kind of condition, we may increase the number of the complex cases even further in the future. So this is a 69 years old gentleman. He has history of hypertension and diabetes, CKD, heavy smoker, and he admitted to the hospital due to chest pain for more than 30 minutes, and also he has a very extensive chest pain. The troponin T is still negative, and under the cardiac ultrasound, the LVEF is about 40%, and you can appreciate the ECG of the patient on the screen. So this is the CAG that we do quite electively for this patient, and we can see that the patient has some total occluded of the LAD, maybe a CTO for quite a long time, and he also has this another bifurcation of LAD and the diagonal, and also we can see from the left main to the LAD, and also the diagonal and the circ is very calcified. So we can see some other projection of the left main LAD and the diagonal and the circ, and we can see that he has some lesion of the bifurcation also. Luckily, the RCA looks quite normal, and we can see some collateral from the RCA to the LAD. So in this kind of case, I think in some hospital where the patient may take right away into the cabbage, since we can see that very heavy calcify of the left main LD and the circ, and we also have the many bifurcation. We can see the bifurcation of both the LD, the circ, and the LD and the diagonal, and we can see that but in Vietnam, the cabbage is some kind of something quite horrible to every patient, and of course with this patient, the patient and the family refuses cabbage from the first time, and so we plan for cheap PCI with the LD, CTO, and the diagonal, and so in this case, we have also the two bifurcations simultaneously of LD, the diagonal, and the left main, the circ, and the LD. And in this case, we have quite a lot of questions before we did the case, like should we do the 6th or 7th French radial or femoral or IVUS or OCT support, or should we do the provisional or choose stand-up front strategy? And what should we do in the cool load or crush if we do the two-stand strategy? And should we do the rota ablation in this case, because we can see a lot of calcification? So in reality, in this case, we use a 7 French view in the right radial and the left French tiger in the left radial, and actually it takes a while, and we use a 5 cross and fill the XTR as the first Y to conquer the LD CTO, and you can see that the Y after a while I will not definite into the technique, but after a while we managed to cross the LD CTO with the Gaia second, and we do the tip injection for the for the LD. And so we try to open up the LD CTO a bit with the 2.0 by 20 compliance balloon. And it's also very hard to wire the diagonal also. And we cannot wire with the normal wire or workhorse wire. We need also the filter XTR to wire the diagonal. And when we wire the surf with the filter XTR, it's very hard to cross the phi cross and even the inverse catheter into the diagonal. And at that time, the wire of the diagonal is also kink that I tried it to PCI under the filter also, but not exchange into the workhorse wire. So I tried to open up the LD more with the 2.5 balloon and open the small the diagonal with the small balloon 20 by 20. And this is the CIG of the patient after we wide. And I try to do the IVUS, and you can appreciate that we have some very tight lesion of the LD, and we can see that in the LD and the circ, we can see many calcification. For this case, the best we can do the rota ablation, but at that time, due to some reason, we do not have the resources, so that rota ablation is quite unavailable. So at that time, we tried to do a kind of the modified balloon. In this case, I use 2.5 by 13 aperta, which is quite a very brand new modified balloon, which is has some special characteristic, like you can see that it has a shape of a triangle with a nylon shape. And in this case, after we do to use a modified balloon, we can manage to put one stand. So firstly, I tried to do the crush technique, but like in this case, we use a 2.5 by 33 Zion Sierra, and which is quite hard to deliver through the filters also. And we can see that in this case, we use quite a lot of pushing to put the Zion Sierra to the diagonal. And this is the crushing of the diagonal stand, and this is the IVUS after we did the crushing and the diagonal stand. So in this case, we also see the very diffuse and calcification of the LD also. And of course, we do not want to put many layers of stand, because we also have another bifurcation in the left vein and the circumflex also. And you see that even we open up with some NC balloon and even the modified balloon, we can see also some calcifications. So the sizing precisely is another problem in this case, because this diagram that I find, because we have the diagonal stand over here, and we need another LD stand here. And if we do not sizing the stand precisely, so we may have in this part, for example, maybe 4 layers of stand, which is quite not good for the patient, and increase the chance to have the stenosis in the future. So the case continued that we put another 2.75 by 33 Zion Sierra by the crush technique to the LED. And then we do the kissing balloon with the 2.5 and 2.75 NC to the LD and the diagonal. And this is the IVUS of the patient after the kissing, and we can see that the stand quite I'm sorry for not getting the video too shortly, but it's still okay to see. And after we do the pot and the kissing, and you can see that the stand apposition and expansion in both the LD and the diagonal is quite nice. So we put another 3.5 by 23 giant sera to until the ostium of the left main, and open up the stand. And well, we did the port with a 40 by 15 balloon. And I think that the port is quite important in this kind of case because we have the bifurcation, and I always do the port with the very complex, and also the left main case like this one. And this is the final angle for the left main LID and the diagonal stent. And well, we can see that the circ is still patent, and there are no signs of slow flow, and there are no signs of the compromise of the circ. So we decided to leave the lesion of the circ alone, and this is the final left main LDI first. This was the distal part of the LD stent. This middle part, and now here comes the diagonal. And we can that, appreciate that the stent was quite opposed. This is the diagonal, and the left main is coming. And also we have quite a lot of calcification. So with the port and the post dilatation and the kissing balloon, we have a quite good apposition of the left main also. So this is my conclusion. The successful complex PCI required quite a good understanding of plug modification, but we are now doing more complex cases, but sometimes we do not have the enough resources. In this case, we do not have the rota ablation, and the PCI in calcified coronary artery is one of the most challenging of coronary intervention. And we also need many technical skills to perform successfully, and we need to familiarize with wide variety. And sometimes we have the very new and specialized equipment to conquer the case. And we have several well-described strategic algorithms that we can use to manage the very complex, calcified, and even the CTO case. But we should adapt to some local algorithms that we can use for the case under the facility that we practice. And this is the final word of my presentation. Thank you all for your attention.
Thank you very much, Pham. I think that was a really challenging case, and I think the only thing that the steps are done. I like the fact that it was imaging guided, because in calcified lesions, that's something that you may need to consider in doing in all cases. I'll ask Wei Chin first. Do you think that we should be enough with just that modification, or would you think about wanting to arthrectomize these lesions?
I have to say that the imaging didn't suggest to me that this is a severe calcification, so I don't think we need to do anything beyond just a high pressure or scoring balloon dilatations. Yeah.
Would you have done anything different? Do you think that the culotte would be your preferred choice, or would you think that you would like to do a double kissing crush? Yeah.
I think the bifurcation lesion is a diameter, is a difference between diagonal and LD. So I think the DK class, I prefer to use it. But this case is a very severe calcified, so I'd like to prefer use the cutting balloon in the main branch first, and use the other scoring balloon in the side branch before prepare the lesion modification first.
So that would be your preferred way of preparing the vessel, because I think it's very important, because you need to prepare the vessels very well. But you would stent the side branch first, right? Because would you tend to, some people do provisional stenting in this case?
Because after the ballooning in the diagonal is a very severe dissection, so I think it's a stent is prefers us, because the very is a dissection as a diagonal.
So I might do differently. Like for the DG, I saw from the IVAS, it looked like a calcium nodule. If I have rotablator, I will rotablate it. And if the result look nice, I will do provisional and maybe kissing with the DCB at the DG to shorter the procedure time. So I try to avoid the cutting balloon in DG, like in this case, because sometimes it causes dissection. And sometimes it's no flow to the DG and the LAD. So I try to avoid, but nice case, nice demonstration. But I prefer provisional with DCB over the two-stent technique.
I would sort of also agree with the presenter because I think the difficulty was the diagonal was coming off at a huge bend. He had difficulty wiring and then ballooning, and it's a large diagonal. I would think in this case because of the fact that the angle of the diagonal is too difficult, it's large. I would also treat it first to be on the safe side because if that closes, it's going to be very, very difficult to cross. So I believe in this case, I personally would do a two-stent strategy. Any last words before we end and go on to the next case?
Firstly, congratulations to Ekip. That is a very, very difficult case. The Ekip choose the right strategy, so they have the good result. According to me, I think in this case we choose the cross decay or cooler technique is better because the serious lesion in the diagonal ostium. So we need to the another technique. I think we cannot cover the ostium diagonal. The most important in this case, I think you have to avoid the triple overlap in the LED or element. But the equipe have do well. Congratulations.
Thank you, Dr. Pham. I think the message here is a double, calcified bifurcation. The imaging was important. The vessel preparation is key. And then he undertook the proper steps, a culotte, a pot. Those are important steps. Do not forget pot whenever you deal with bifurcation lesions. Thank you very much.
Thank you, Mr. Chairman.
Okay, so we'll move on to the next presenter from Hong Kong, Dr. Eugene Brian Wu. And once you rota, there is no way to gota.
Thank you for the kind invitation for giving this talk. Regret is what you feel when you feel sad, disappointed, or sorry when something bad has happened. And this case is full of regret. It's important not to let regret go into depression, because that's when things go really wrong. So this is next slide. This is a 67-year-old woman. Yes, okay. Who is diabetic, hypertensive, hypercholesterolemic. She underwent a coronary artery bypass graft in July 2022 with a lima to the LAD, with a vein graft to the PLV, and a vein graft to the OM. Unfortunately, within 2 years, she returned with unstable angina. The angiogram shows that the lima has an anastomotic site occlusion. The vein graft to the right coronary is very thin and only has subtotal flow. The vein graft to the circumflex cannot be found, which means all her grafts are down. She has a proximal to mid-LAD diffuse calcified lesion and a right coronary CTO with an EF of 55. And this is the case we have before us. You can see this is the post-graft sternal rings, and you can see a long calcified LAD lesion that goes all the way back to mid-left main at least. The circumflex you can see is got long diffuse calcified disease. And you can see in the circumflex, there's a high-cut point in the OM1 where the graft is, and you can see the sort of reverse filling of the stump of the graft, but it doesn't fill much more than that. So although we haven't found the graft from the aorta side, we are pretty sure this is occluded. And the RCA is a mid-RCA occlusion. The lima, you can see, runs down and kind of peters out in mid-thorax, and you can see the last bit of contrast just drifting down to the anastomotic site. This is the vein graft to the right. You can see which is really a little thread that doesn't supply anything. So we began by wiring the LAD, and we thought, well, this patient, normal EF, should be a simple case, mainly some arthrectomy, but we found it very difficult to pass anything down the LAD. So when you have a calcified LAD, you can't pass anything down. We go to our good friend, the rotablator. So here is the rotablator. Unfortunately, once we started the burr, the patient started to drop his blood pressure. Now, we made several mistakes when we were doing this rotablation. I think first, the burr started and stopped quite a lot in the left main, and because the left main is quite diseased, the burr sitting in the left main meant that the flow down the left main wasn't good. Secondly, the guiding also damped a little bit, and that also caused the blood pressure to drop. And you know how it is. You're doing it, the blood pressure's dropped, and you think, well, the guiding's not so good. I'm going to pull back the guiding a little bit, but the blood pressure still remained low. So we took it out and did an angio, and what happened was we occluded the LAD during rotablation. The rotaburr at this point still hasn't passed the mid-LAD. And the patient is starting to become very hypotensive. The systolic is around 60 at this point. And we decided to quickly balloon the LAD with a small balloon, a 1.5 balloon, to try to open that flow to the LAD. And so we got flow back in the LAD, but the patient persisted in cardiogenic shock. So we're now feeling a lot of regret about our decision to rotablate. And we thought we'd better do something strong now to make sure that we get through this. So I think you all guys have all been talking about impella, and so of course you go to our good friend, the impella. So here's the impella in, but when you put the impella in, sometimes the impella knocks on the LV wall. And this sometimes triggers ventricular fibrillation arrest. And now we're feeling very regretful. We've chosen two of our good friends who usually help us, the rotablator and the impella, and they both put us in a really bad state of depression. So the patient went to VF arrest, and of course the impella is not enough to sustain VF arrest. So after defibrillation, the patient went back into VF arrest again, and after a little bit, we began CPR, and we put onto a Lucas device. And now we have impella Lucas support. And we thought impella Lucas, we might be able to do a bit of PCI, but the small balloon cannot open the LAD. And the LAD just cannot be opened like this. And again, the patient is going back and out into VF, and we're doing more defibrillation, CPR with Lucas, impella support. So at this point, we're filled with regret. So we decided we needed to do some more rotablation. Although we are sorry that we used the rotablator the first time, we need the rotablator to open up this vessel. But we cannot do rotablation with Lucas and impella and defibrillation at the same time, because the things will move back and forth too much movement. So now we decided that we're going to use, so this is how much movement we have, you see. Lucas and impella, very hard to do rotablation. So we put in, the balloon cannot open. So what do? So we did something here to make everything slow down and stop. And it's called the ECMO. So we put an ECMO impella Lucas. Now we don't need the Lucas, because once you have the ECMO, the Lucas can rest. And of course it's much stable now, because the blood pressure is stable, we have perfusion, and the impella is venting the LV, so we can rotablate. It was not an easy rotablate, so we are glad we put the ECMO in, because now it allows us to really spend time to do good rotablation. And you can see the rotablation is not easy. It cannot pass the mid-LAD, and took quite a lot of runs. And finally, we could get through this at the very end of this run. There we go. So then we ballooned this, IVIS this, stented this, and I won't bore you with this. Did the pot, very important to do pot, stent the left main, and we did the IVIS to check. And then we wired the circumflex. And I wonder if you know what I'm trying to do here. The wire is wiring the circumflex. I'm wiring the graph. Just because the graph is in a better position to hold the wire. Then, of course, after we wired the graph, we did, I wired it out to the aorta. maybe I'm missing doing retrograde CTO at this point. So I balloon opened the os of the circ and did a kissing of the left main, and then report. And then we put a mic cat, this is fine cross, up, just to document that the graft is occluded with a small injection. Careful not to go too near the aorta in case you squirt some plaque or thrombus up and cause a stroke. So this is the final result. And after stent optimization. So in summary, we did a rotablator, and I think there's some points we learn about rotablator safety. I think if you have a diseased left main that's diffusely diseased and the rotabur resting there is going to cause ischemia, it's probably worth burring from the guiding because rather than occluding the left main all the time. We need to be careful with guiding damping because that contributes towards the shock. ECMO is obviously a stronger support than impella, and I think sometimes, although we love to go to the impella as a first device, sometimes if you have the patient's already resuscitating, there's recurrent VF, ECMO just allows you a more stable platform for you to work on than the impella. Of course, ECPella is good if you have the finances to support that. Probably we shouldn't have wasted time with continuing trying balloons because this case, we couldn't burr past the LED even at the beginning, so the chance of balloon being able to work was very low. Luckily, the patient is still alive. He has some anterior hypokinesia because, putting an impella takes, 40 minutes, putting an ECMO takes 40 minutes. So, he had significant ischemia on the LAD for, over an hour. So, but at least the patient is alive and survived. So thank you for sharing my deep regret and depression, and I hope that cheers you up.
Thank you very much. Splendid work, Brian. So we only have impella, so I think this patient will probably not survive on our side. But Frankie, first, would you have put in an impella before?
Yeah, I think that's a very important lesson for us to learn about the use of different MCS. So ECMO, impella, or whatever you have. But the fact is, once the patient is cardiac arrest, right, impella is not useful because impella is sucking blood from the LV, right? But if the heart is stopping, it's not pumping, VF whatsoever, there's no blood go from the RV to the pulmonary circulation to the LV. So when the patient has a cardiac arrest, just impella is not useful. So at that time, probably ECMO will be a faster stuff to make everything, to reverse everything. But in this case, impella, Lucas, hopefully both will work. And when the heart stabilizes with the impeller, then you can proceed with PCI. But many a time, if the patient has cardiac arrest, VF, probably just impeller is not going to work. So I think this is a very important lesson for us to know which MCS to choose.
Would you have put it in the beginning?
Oh, so this is again a very difficult situation. So for all the impeller stuff, they have different score to decide where to put preemptive MCS or impeller before PCI. But most of the score actually need that the EF to be low. For example, in Hong Kong, for the funding, the patient have to be low EF before the government can reimburse the impeller. But again, we have similar cases like Eugene. Right? EF's normal to start with, but once we get rota, LAD closed down, hypotension, VF, then this is very difficult. But of course, if cost is not an issue, probably some case impeller may be useful. But if it costs the issue, reimbursement, then I think most of the reimbursement system will not allow us to put impeller in a normal EF for the impeller.
Could you identify yourself?
Yes, thank you. I have an idea because the idea is the shock of patient due to the guiding catheter. Because you see the lesion is the left main. And the lesion in the LAD is diffuse and calcified. And during this PCI with the P-dilate with balloon, when we move the balloon outside and guiding catheter go inside. So to prevent the shock from this patient, the first we need to make the hole, 2 holes beside the guiding catheter, especially when with the 7 guiding catheter. It's my experience.
Yes, we argued about side holes extensively in the global CTO consensus group. and it was one of the topics that I received over 40 emails on. So if you're not aware, the paper for Global CTO Safety Consensus was a paper published by me with 147 authors around the world. I think many of them are here, actually.
We can make the whole side by hour.
And so we debated side hole
Yes.
a lot. And I think about half the authors thought side hole is a bad thing because it masks the damping effect of the guiding catheter. The other half of the authors thought side hole is a good thing, like yourself, saying that it's going to be great, you have some flow down the left main, and that's a good thing. In the end, the paper stood on your side. In the end, we said side hole can be recommended. But I have to say that whether side hole is really very helpful in guide damping, whether it masks it, is still very debated in the world of intervention, from my experience of writing the paper, of course.
Yes.
But yeah, side hole may be helpful, maybe helpful.
I like to believe that an ounce of prevention is always better than a pound of cure. So in this particular case, I don't think there's anything wrong with the strategy, but I think in terms of the timing of the procedure, I think this is a high-risk patient, triple vessel disease. I'm not sure about, I can't remember the EF before the procedure, but this is a high-risk patient that I would have upfront put in even a simple intra-aortic balloon pump would have done the job. And the second point here is that actually there's nothing wrong with choosing rotational atherectomy because your threshold for using it must be very low in this case, given the extent of the calcification. I just don't know what is the size of the burr that was used here. I will probably start with the 1.25.
Yeah, same. We are 125 burr.
Just to make sure that I get a burr. But if I have difficulty going through the lesion, I would have no qualms in upping the speed of the rotational atherectomy just to get the atherectomy across the lesions. I think once you go into a rescue situation, it's a very difficult situation already. So, but anyway, that was a good salvage. But I would thought that perhaps maybe an upfront protection and perhaps a high-speed rotational atherectomy might have helped you a little bit.
Yeah, so we started off with 180 for the rotational speed. And upfront is exactly what Frankie says. The funding for us, unfortunately, with normal EF is not included. And the price is outside the range of what the patient can afford. So,
yep. Okay, but I think most institutions will probably have an IBP, and it's been shown that if you want to do upfront, it's better than when patient crash and you put in IBP, and that's the point that.
And that's a very good point because you can, if you do good puncture for the IBP, you can swap out for impella through the IBP later on as well. So that's a very nice way to do it.
Right. Thank you very much, Brian Wu. So we'll go on to the next, which is by Liew Houng Bang, tips and tricks for DCB intervention in CTO lesions from Malaysia.
Thank you, Dr. Rosley, and congratulations, Dr. Hui and your team for your first meeting, and thank you very much for your invitation. I'm going to share about the tips and tricks for DCB in CTO lesion. And before I start, I'd like everybody to listen with an open mind. This is not to tell you what to do. This is more of a sharing. If anything, I hope it may provoke some thoughts, create some intellectual curiosity. Let's start. Special challenges in CTO, as we know. Often, these are patients who may have a history of infarct, so their airway function may not be normal, maybe viability issue. Sometimes, some of these patients may even present with an acute occlusion with a background of chronic occlusion, and they can be very ill. These lesions generally are very complex. They can have ambiguous entry. The cost of the CTO can be ambiguous as well. And of course, collaterals may not be well seen. Lesions may be long and tortuous, and often, as we've seen in cases like earlier, calcified and even have hidden bifurcations. One of the main challenges for interventional cardiology for CTO is whether we can cross. We can't cross, we can't proceed. And to cross, there's option to think of antegrade, retrograde, and of course, we can also look at how we maintain the wire within the lumen, intra-plaque as much as possible. Occasionally, intentionally or unintentionally, we might even have to go extra plaque. Part and parcel of the procedure and lesion preparation will involve plaque dissections and hopefully not perforation. There is some challenges with CTO because the tendency for undersizing. These vessels are chronically occluded. They are either underfilled or they are literally negatively remodeled. When we put in stents, there's always a tendency to use long stents and full metal jacket. And these has been clearly associated with high risks of late stent failure. And of course, we know CTO has learning curve. It's a costly affair, and the technology that we have to invest in, the technique that we all have to learn, and the time. Having said that, there is some good trend. The trend of angiographic success and complications CTO has shown here is good. So success rate has improved, complication rate has come down, with both improvement of technology and technique. However, when we look at the contemporary use of stents for CTO, this is from a systemic review, looking at many patients, close to 10,000 patients. We can see here, when we follow up these patients, long term, the rate of MACE continued to go up. At 12 months, at 24 months, at 3 years, at 5 years, it can go up to more than 50%. And issues like stent thrombosis or re-stenosis. Full metal jacket particularly has been shown to have cumulative incidence of target lesion failure. So with that, we had to ask ourselves, are we continuing the stents preferred strategy, or we should consider options like DCB? So there is a concept that we have to embrace, vessel remodeling after CTO. So after CTO, PCI, the distal vessel often may be suboptimal because they're diffusely diseased or negatively remodeled. And they will undergo significant post-remodeling with time. And this means we have to repeat to have a look. Warrant retreatment, even sometimes intentional relook. And stent segments may be good at the time of the index procedure, but when we relook, we might actually find that the stent is undersized as the vessel expands. And this is when we say there's a late malapposition. And we have to think about additional scheduled procedure to optimize the procedure. Here's a story of 2 CTO, both LAD, and I will show the first one, which is DES. As we see here, we crossed it, we stented. The proximal has a 3/38, looks good at the time of procedure. But when we follow this patient in 15 months, if we look at from a QCA perspective, we do trial, we will say, hey, this stent is patent. There's no failure here. But when we look carefully, we will observe that the distal segment of the vessel actually has grown larger, showing that the proximal stented lesion, stented segment now actually looks slightly smaller. Given time beyond the 15 months, 2 years, 3 years, 5 years, we will foresee a higher risk of restenosis. On the other hand, the other CTO that we choose to treat with a DCB, at the time of procedure, we have recoil, we have some dissection, but they're not life-threatening. And we are patient to review these patients, then we bring them back. There is an opportunity for vessel to remodel. As we've seen here, the vessel becomes larger. So I like to urge everybody to have a look at this paper. This is from a CTO ARC consensus recommendation. And it talks about this concept that we need to consider, that we have to think about modification of the CTO optimization procedure. Meaning, in short, that not all CTO has to be a one-off procedure. That we have to consider that these patients need to return to have a relook intentionally and to optimize. And from the recent European meeting, this emerging concept is again advocated, that we need to consider this innovative strategy to treat CTO. And I'd like to highlight this sentence, which is here. Plan investment procedure with a cumulative procedure success and safety, meaning not just one procedure, but having 2 procedures or even 3 procedures. Main thing is to look at the long-term benefit of not stenting full metal jacket. So here's an option. We had to think about having a CTO like this when it is very long, that whether we upfront, we like to have a very, very good-looking vessel with long stents, or we're willing to invest with DCB and come back with a second procedure with the possibility of doing more procedures or sometimes good enough. Where's the evidence? At this moment in time, we do not have a lot of evidence because we don't have a lot of studies that look at long term. And we need to look at not just the acute, the procedural success or not, but also look at the long term. And part of the plan is to look at it from a cumulative procedure strategy. We do have some insight. This is from a 2022 series of CTO that we treated. And in this series, we learned from a few things here. For instance, majority of our lesions here that we prepared in CTO have dissections. And the sections can be up to 74%. But when we're willing to follow these patients, the dissection actually majority will heal to less than 5%. And we will look at another paper that is from the peripheral intervention. They also talk about the intraluminal and subintimal wiring and the use of DCB. And this again shows that if we have the patients and the possibility of wiring the true lumen, intraplaque, the intraluminal DCB angioplasty is better than having subintimal DCB. What is the mechanism of the late lumen enlargement is probably multifactor. It is probably the vessel enlargement from the mechanical expansion of the balloon as much as the plaque regression over time. All in all, we observe about 74% late lumen enlargement. Currently, majority of these are observed with the paclitaxel drug-coated balloon. The section index is one of the strongest predictor in the change of lumen volume. So having some dissection is actually favorable. In a paper recently from Yamamoto, it gave us further insights, and in this case, these series have about quarter of the cases are CTO, 24%. And when we look at the practice here, scoring balloon was used 100%. And when we look at the scoring balloon diameter, it was about 2.5, and the scoring pressure was 9. But what was not of course, elicited here is actually the duration of the balloon inflation, which I personally feel is an important factor for the shear force on the vessel wall. But it's also important to note that when we look at the DCB diameter, it is 2.6, which is more or less 1-to-1 of what the scoring balloon has done. So I think this is an important message that we have to have optimal sizing of lesion preparation followed by DCB. And this has been shown before that scoring balloon do improve results, reduces restenosis rate. A quick look at our experience. We started with CTOs, DCB somewhere in 2016-17. We used to have a lot of stents, and then we have less stents, but more DCB for their first procedure as an investment strategy. And we have yet published our data, but it's just a bit of insight of what we do. Majority of these cases we are treating an ILAD, and these are all antegrade cross lesions. The PCB was used in majority of the cases. Dissection at time of index procedure was 70%. But again, these are patients who are stable. They are not in pain with the vessel occluded on table. This is not ATO. So in that sense, we have more confidence to accept dissections. As you see here, when we follow up, not all these patients, the handful of patients that we can follow up, we noted that majority of these patients have no restenosis. So if I'm the patient, I take my chances. As I keep an open mind, I don't want a full metal jacket up front. I'm willing to take my chances, 50-50 or 75-25 to return with no restenosis, and 25% a repeat treatment with less stents. So here's an example of a patient with LAD CTO from the osteo, and we prepared the lesion, long procedure, usual. We had to cross it, we had to wire it, and then we started with small balloon. Initially, we had to use very small balloon because it was tough crossing. And after that, we had to use scoring balloon. And after that, we had a look and say, hey, this vessel looks very small. And often we have say, hey, is that the true size of the vessel? We know that LAD mostly are actually 3. And either we do imaging or not is an option. And for this patient, I go with my gut feeling. I say, hey, this patient, we will go with a 2 in the distal, 3 in the proximal. So we do, instead of full metal jacket, we treat with overlapping DCB. A 2.25/30, a 2.5/30 with a 3/40. And this is the result after the DCB. We can see dissection, we can see recoil, but the patient is pain-free. We bring the patient back in 9 months, we see positive remodeling. So this is not one-off. I would invite people to start experimenting. The paradox with the CTO is these patients, if we select them correctly, single vessel CTO, EF preserve, we can try this. And we do see patients, good healing. And we have patients that we can follow up to 5 years, and we see results that sustain. So I urge as many of us here to try an open mind. Keep an open mind, as I mentioned earlier. Have an intellectual curiosity and humility to do something different, not just stents. So my practical strategies, I would say, not just tips and tricks on DCB CTO, are as follow. I still believe patient-centric is important, that we have to know who are the patients who will benefit. I learned this from EuroPCI when I was a young fellow, and I remember one of the meeting, in the beginning of the session, they told us, you're not here just to learn how to do. You got to know when we could or should do. Likewise for CTO. Principle 2, for all DCB strategy, optimal lesion preparation is the key. The plaque, whether there is calcium, we have to modify, we have to debulk, we do so. And in the CTO setting, crossing intraplaque as much as possible. If we have to get out the plaque, keep it short. So we have minimal false, as much of true. Then hopefully the balloon will work well. In terms of ballooning strategy, I got to put my hands up. We go by the current evidence that we have. We should have one-to-one sizing. And again, what do we mean by one-to-one sizing? One-to-one sizing by angiography is the lumen of the normal or the near normal. If we go by intravascular imaging, we might say 1.1 to 1. Because why? We may look at the media vessel size. In a CTO, I have to say, we can only say the vessel is as so at the time of procedure. We have seen patients where the vessel at the time of procedure was 2.5. When we bring the patient back, it is a 3.0. But we cannot go in with a 3.0 balloon when it's a 2.5. We'll rupture the vessel. So we have to be patient to bring the patient back to have a look. Principle 5. The ACB preferred strategy will allow positive remodeling, and we had to accept that imperfect lumen as part of investment and delayed re-look for optimization. TIMI2 flow may be acceptable sometimes in CTO, and this is inconsistent with the consensus that I mentioned, because when you have a very strong retrograde flow, that is okay. When we bring the patient back later, we might find that, hey, the flow improved. So we don't have to compel ourselves to bail out a stent just because it's TIMI2 flow, not in the CTO setting. Principle 7, often suboptimal lumen despite best preparation effort. This is where we have to use clinical judgment. If it is important to put a stent, we have to weigh the acute and the long-term benefit and risk of a suboptimal undersized stent. Last but not least, the option to combine DES and DCB. I urge the company and everybody who are advocates for DCB not always to say it has to be stent-free or metal-less. Less metal maybe, but not always metal-less. You always have to use the judgment to ask ourselves where we have to stent the footprint of the lesion prepared and where we can accept DCB as an option. My conflict of interest are as follows. I come here under B. Brown sponsorship, but I work with all the companies with DCB. We're currently doing trials for DCB involving the reverse, which is large vessel de novo, and hopefully more studies in the future. Hopefully more of you will join the bandwagon. Thank you very much for the opportunity to share.
Thank you very much. I'm going to open for about 4 minutes to discuss something which is thought-provoking and something that a lot of us may not be willing to perform. Any questions or comments? Yes.
Uh, Thank you for a very interesting lecture. So I have a question about in the CTO case, a very diffuse lesion, but proximal a very large vessel. But recently, a study presented at ESC about the right case free from China is the compare the large vessel in the inferior to compare to the yes. What do you think about the practice?
Well, that was a very thought-provoking study indeed, but it is one study, and we have actually looked at critically appraised that paper. A few things. One, the paclitaxel balloon that we are talking about is one brand, and the drug elution dynamic is very short. The effect of paclitaxel is nearly gone within the first month, and we know the biology of vessel healing takes longer than the first month. So we think this is a major factor. Apart from that, we also have some insight looking at how the procedures and the investigation sites. For instance, that there was a very high bailout stenting post-DCB, which is unusual, 9%. We suspect that maybe these are learning curve, that most of us who do DCB, we don't bail out with a stent post-DCB up to 9%. Currently, we just review our reverse. I hope I'm permitted to say this without getting into trouble. We just review our event from our reverse study. And so far, band stay out rate is less than 1%. And our event rate is also considered low, good enough for the independent data safety monitoring board to tell us, please continue the study.
Yeah. Thank you for your presentations. So I would like to know about the, after we got the wire into the lumen, and then how to decide the size of the DCP. Because I just worry about that, whether we have used the iverse to measure the true lumen for that. Thank you.
Yeah, so it goes back to the principle of whether we are confident to size a vessel by angiography. If we have a short CTO and we have good lesion, we have good vessel, distal, either angiographically or iverse, then we can size it. But if it's a very long diffuse vessel, very calcified, often these vessels are very chronically negatively remodeled. My advice would be to go minimal with the sizing, not to perforate, but create some flow. I believe that there's some biology about blood flow when it is in contact with endothelium. There is some reactivation of endothelial function, and that is not going to be immediate. We have to accept that PCI in this sort of setting should not be instant gratification. It has to be an investment. Don't put a full metal jacket. Bring the patient back. Have a look. I know every country has its limitation, the system limitation of how DCB are being funded and so on. But from a scientific context, this is what I recommend. Don't stand when they are very small and diffuse, but bring them back and have a look.
Thank you.
One short question. So thank you for your fantastic lecture. May I ask about the target vessel failure after you using DCB in CTO in your center?
So based on our first case series of about 34 patients that we published, we analyzed the TLR rate. If we have short CTOs, we prepare the lesion well, they fulfill what we call the German consensus, that there is less than 30% recoil, there's no type B dissection, more than type B dissection. These has very low TLR rate, single-digit TLR rate. But when the consensus criteria are not fulfilled, the target lesion failure rate close to 45%. But to me, the first procedure failure is not a long-term failure. This patient now can return for a retreatment, hopefully with a shorter stent and a larger stent, not a long and small upfront foot metal jacket. That's the key message.
With that, I'd like to thank Dr. Liew Houng Bang. Anyone who's interested, please go up and discuss with him afterwards. And he's a true believer, especially in CTOs. So we'll go on for the next session. Thank you. Which is case number 7 by Dr. Huynh Huu Nam. and it's on completeness of coronary vascularization in an AMI patient coping with balloon-uncrossable lesion.
Thank you very much. Dear Chairman and colleagues, I'm a Dr. Huynh Huu Nam from Da Nang Hospital. Today, I'm deeply honored to represent the team of cardiologists in my hospital to present with all of you in this conference about the topic, how could we cope with balloon-uncrossable lesion. I think this is the situation we face day by day in cath lab. And uncrossable lesion is the lesion we successfully crossing the line, but the balloon cannot cross. So this occurs commonly in the CTO lesion from 6 to 9%, but it can occur in non-occlusive lesion. And it's always challenging. Commonly encountered in PCI, particularly in tortuous and calcified artery, as well as CTO. And this research says that it takes more longer time for a procedure and more radiation dose and contrast volume with the lower rate of procedural rate success. Based on the mechanism of the lesion, so there are three mechanisms can cause the balloon cannot cross the lesion. That is the severe calcification. And the artery has acute angle and tortuous, and also very tight, narrow, and CTO lesion too. It can happen individual and maybe combine those things. To illustrate this situation, I would like to present the case. This is the female patient, 72 years old, admitted to my hospital 3 months ago with a chest pain. She has type 2 diabetes, hypertension, dyslipidemia, and no other CVD risk, and also no family history of premature CVD. She has the symptom 5 days before admission with a short burst of chest tightness lasting 3 to 5 minutes. And 3 hours before admission, she has a chest pain get very worse. And last more than 30 minutes, she went to my hospital. On admission, the heart rate is normal, blood pressure is a little high, saturation is okay, and no overt symptom of heart failure and CCS3 angina. And the patient was tested in the ER with troponin, this is positive, and was diagnosed with non-elevated MI, and was treated with loading dose of antithrombotic and statin, and admit to my hospital, my department. This is the CTO on admission. We see the T wave, negative T wave in V2 to V6 and D1 and AVL. On test result, the patient didn't have anemia. LDL-C is a little high. Troponin with 3 hours apart with dynamic change, and NT-proBNP is high. GFR okay. On echocardiography, the patient have mild dilated left ventricular chamber, mild concentric left ventricle wall thickening, and hypokinetic in septum, interventional septum, and apex. And EF about 45%, rate to diastolic dysfunction. TAPSE is okay, and a little high pulmonary hypertension. And on X-ray, we can see a little congestion in the lungs. And the patient was diagnosed with high-risk non-SD elevation MI, no ARC, high-risk, high bleeding risk, type 2 diabetes, hypertension, and heart failure. And was treated with antiplatelet and statin high dose and heart failure regimen and diabetes regimen too. And plan for optimal medical therapy, of course, and angiogram less than 24 hours. On angiogram, the right side is quite normal. In the distal, in PDA with a very severe stenosis, but the branch is still very small. From the caudal view, we can see the tight, severe stenosis in distal segment of circumflex. And from the cranial view, we can see very tight and calcified from the lesion in the proximal and mid segment of LID. And the patient was diagnosed again, high risk, non-ST elevation MI, no high bleeding risk, tight stenosis of LD and circumflex, heavy calcified lesion, SINTA score 19 point. And I also count SINTA score 2. SINTA score 2 recommend us to do both. We can choose PCI and CBG with 4-year mortality is the same, maybe the same. So we discussed with the patient, and the patient choose PCI. And we predicted that this is a very tight and calcified lesion in LD. We go by femoral access, by EPU 3.5, 7 French. And we use body wide in LD. We predilate with the small balloon, NC balloon, scoring balloon, and also we set up the rota bladers atherectomy system to prepare also. I was needed. The first time we wind to the lesion in LD, it's very hard. But after trying, we can go through 2 wind. And the first technique we do is we use the Berkeley wind, and we use very small balloon, 0.85 milliliter, nano hydro balloon. But we cannot cross. After that, we try to deep seat the catheter, but it doesn't work too. So angiogram after failure across the balloon is the same. We cannot do anything. So we plan again. Maybe we have to try 2 techniques to anchor balloon from circumflex. You remember the patient have a lesion in circumflex. So we put a stand there and maybe use the balloon to anchor from that side. The circumflex intervention happened smoothly. We put the stand, DS stand 2.25 millimeter. And after that, we angiogram, it's okay. But after we anchor balloon in the circumflex, the balloon 0.85 cannot cross the lesion in the LRD. So we need to set up the rotablation. And we did the run for 5 runs. After 5 runs, we successfully go through the lesion. And we choose the burr of 1.5 millimeter. And angiogram, after successful crossing burr, we can see, oh, sorry. We can see the tightest area of LD is open a little bit. And we can cross the balloon, SC balloon 2.0. We inflate 18. After that, we used an SE score, an SE scoring balloon, and we did IVERT. On IVERT, we see that in the reference EEM in LISTA about 3.30, so maybe we choose the stand 2.75 in LISTA. And at the ostium of the LRD, the MLA is about 2.8. So maybe we cannot engage the, put the stand in the ostium. We need to cross over to the left man. And on the IVERT after NC balloon and SE balloon, we can see very severe calcification, but it's, sorry. But it's ruptured already. And it's easy to put the stand on the distal with 2.75 and in the proximal 2.5. And we do NC balloon after that and bought with the balloon in the left man 4-year-old. This is the final result. And on the IVERT, we can see it in the tightest area, the stand expand very good. The MSA 5.2. When we compare with the distal, the MSA, MSA MLA is 5.2 also. The patient, after the intervention, the patient was treated with the standard therapy and discharged 3 days later. And symptoms got better after procedure, and currently she is not chest pain and dyspnea. So for discussing this patient, I think most of you have your own strategy. And I review in the literature, they say that we have 3 strategies to deal with this situation. The first line strategy, we have 7 options. The first thing we have to think about the guide catheter support. And the second is balloon selection. The third, we can use the extension guiding catheter. And fourth, Y-based support technique, and ankle technique, micro catheter, and Y cutting technique. This is the first strategy. The second strategy, we can choose the balm, be a balloon assisted microdissection, or we LCAR, or we can use the rota laser. And the third, I haven't done it yet. I hope you can share your experience if you do this. This is the dissection reentry. So let's look about how to get the stronger guide catheter support. We can use the suitable catheter, and the larger catheter can provide more stronger support, and the longer sheet sometimes can enhance the stiffness of the guide. So sometimes you should deep seek and use the Berkeley wine or guide catheter extension. And choose the suitable balloon is extremely important. You use the small balloon, single marker, and compliant balloon with low crossing profile and long length. The balloon profile is high at the marker, so you choose the marker from in the mid or proximal. It's better the marker in the distal. And sometimes you push forward and pull backward. It can work because this comes from the theory that the dynamic friction is less than the static friction. And sometimes you use the balloon wedge technique. So you inflate balloon while you maintain forward pressure to the cap of the plaque, and sometimes it can work. And try new small balloon or balloon manufactured by another company, and try larger balloon to modify the proximal of the proximal cap of the artery and plaque. Here is some information about the tip entry and crossing profile. Take a look, and you can choose one of those. But for me, I think Sapphire 2 Pro, Tazuna 2.5, and Nit Nano Hydro 0.85 have the lowest profile of tip entry and crossing profile. Guide catheter extension can help you to improve the strength of support, increase support, and push highly resistant lesion. And you can choose the guide liner or guide zilla, and you can use the 3 techniques to advance, like surfing technique, inworm technique, or ankle technique to inworm advance the extension guide. And this is the illustration how to anchor balloon. And we can combine anchor balloon and extension catheter. We use 2 catheter. And one catheter we advance extension catheter. And another we advance balloon. And the balloon trap the extension catheter. And it can cross, it can help to more stronger to push the balloon. And sometimes we use the extra sport wine like a wiggle wine or Berkeley wine. And microcatheter, you should choose the coin microcatheter. It can, in particular, need to spin quickly in order to reduce friction. And this is the cutting wine. So you inflate the balloon with a side wine, and that's why can cut the plaque. And you can use the seesaw technique and balm technique. you rupture, you create a micro dissection around or into lesion. This is the illustration of BAM technique. And sometimes, if you have this one, I think it's effectively, and rotablator is effective in this situation too. This is a very skillful and some can cause complication. That is the re-entry, dissection re-entry. So for concluding my speech, I would like to say that uncrossable lesions are challenging always. Three strategy help operator gain the general overview and make appropriate choice to cope with the challenge. Always prioritize the patient safety. Choose technique range from those with a low complication to high complication. And sometimes stopping can also be the victory. Thank you very much.
Thank you. Always challenging uncrossable lesion and SIF calcification. Any comments from the panelists from on my right side? Anyone who wants to? Yeah.
Yeah. I'm sorry. How many time? How long for this procedure?
Wow, this procedure is taking about 1 hour, 1 hour and a half.
Yeah.
Yes.
Very good. I think you can stop after PCI, LCS, and LED for next time.
Next time.
Yeah. And another thing, if after you can cross a balloon, you can think about rotaplator for LED. I think LCS you can do the next time. And I think with anchor technique cannot help you do for LED. I think in this case, after can cross a small balloon, you think about CIBG or rotaplator. I don't think your cath lab you have a lot of things to do for patient.
Yeah.
Yeah. So good for patient in Quảng Nam.
Đà
so
Nẵng. Yeah. Đà Nẵng.
Đà Nẵng. Okay, Đà Nẵng. I think with this patient, when you do LCS and you transfer and continue with rotaplator LD, you have prepared a lot of things to rescue the patient.
Yes.
If there are some problem.
Yes.
Shock. Yeah. Do you have AIBB, ESMO in your?
Yeah, we have.
Lab?
We
yeah,
have.
I see.
Yeah.
Good. Thank you.
Yeah, thank you very much.
I think in this case, at first you can use the, when we use the small balloon, and then you can inflate higher pressure, and then they can make the balloon broken, and then you use another new balloon to do crossing. Or sometimes we can use the co-share to break the calcified lesion. If it not works, maybe we choose the rotablator exactly as you do. Thank you very much for your presentation.
Yeah, thank you very much.
I think you can shorten your entire procedure by changing your strategies. I think the moment you have a problem in terms of wire crossing or balloon crossing or imaging device crossing, switch immediately to rotablation, because don't waste time doing anything else. Rotablation actually does not complicate a procedure. It simplifies your procedure so much so that after that, your facilitation of balloon and stent will be a pretty straightforward event.
Yeah, thank you very much.
Yeah, but this again, to stress, people are so afraid of rotablator because of procedure complications and so on. But once you learn it, then you know that this is probably one of the first device to get you out of problems and get good results. Thank you very much.
Thank you very much. Thank you.
Yeah, I mean, it's for general. So yeah, Dr. Alan Chan from Hong Kong on ultra low contrast impella supported PCI in patient with double CTO. So we are probably going to take about 5 minutes over time, enough for you to go for your lunch, Simpu, after this.
Okay, thank you, Chairman. So I think we have a nice sections. I think the last case is
is good because it's just put everything together, everything of the. We have the calcified case, we have CTO, as well as impaired function. These go straight to the cases, 65 years old ladies with history of diabetes, hypertension, CKD with a EGFR only 30s, coming with non-STEMI heart failures, EF only around 25, global hypokinetic. We also did some variability studies show only apical infarct only. So you can see the baseline angio over the right side is the CTO. It's very calcified fluoroscopy on the right as well as from the left. So the RCA CTO is long. I will show you the left side. So the JCO score for this one is 2. Okay, this is the left side. So you can see the very good cholesterol from the LAD. The LAD also was occluded in the mid-LAD segments. Lepmin was a bifurcational disease. This is a long diffuse disease over the circumflex arteries. So this is, in fact, a triple vessel disease, 2 CTOs, left main bifurcations, impaired LV in the ACS heart failure patients. So this, in fact, contribute all the domain of the achieved patients. In talking about anatomy, you have a left main bifurcation, multivessel disease, calcified, and well CTO. Clinically, the patient also have a diabetic CKD as well as non-STEMIs. And for procedural point of view, very likely this patient require atherectomies together with left main bifurcation stentings and retrograde CTO PCI. The author of the global CTO algorithm is here. Probably if you're doing CTO, very likely we will refer to these papers. You illustrate how step by step we want to choose the right strategy for the patients. And in this particular case, for the outset in particular, very likely we will use retrograde interventions. So our strategies, talking about we use upfront impeller supported PCIs. Because of the CKDs, we try to use minimal contrast approach, but more importantly, use IFS guidance. So because of the cost consideration also, we need to anticipate left main bifurcation, retrograde CTO, calcium modification techniques, including atherectomies. Very likely we try to incorporate all the procedure in one go in order to save the cost. Of course, we can able to put in the MCS twice, but it double the cost. So minimal contrast is the key to order to put everything together. We try to tackle the outside first using primary retrograde approach to the outside and try to tackle the left side subsequently. So it is the strategy. We have bilateral injections first through the right radial arteries. We put in a impeller CP through the right groin, and then through the impeller CP shift, you can do a single SS, putting a 7-slender shift for the antegrade interventions. This is the so-called single SS approach for the impeller supported PCI. So at the beginning, we always important to measure the EDP because we will guide us to give fluid at the beginning of this patient. Because patient are already treated with, out of heart failure, diuresis adequately, so the patient is quite stable. So how to perform ultra-low dose contrast PCI? This is one of the good review articles if you are not familiar with. So first of all, you need to understand the risk of the contrast-induced nephropathy, knowing about the EGFR. You try to calculate the volume of the contrast you can to give, and then you try to confirm using the ultrasound as well as IFS to do the procedures. While doing ultra-low contrast, usually imaging guiding is the key. You will try to locate where exactly is the anatomies, where exactly you want to locate your stents. For engagement, actually you can use the so-called saline test. Whenever you touch the ostium of the coronary artery, you give you flush with the catheters with saline, and you can see this EKG change. We don't need to do a contrast injection. Of course, you can also do the wire fishing to try to wire the coronary artery using the anatomical lemma as well. So going back to the case, this is the schematic diagram over the retrograde injections, I think from the LAD. You can see there's a lot of collateral supplying from the LAD through the septal branch. So you can use these to tackle the CTO intervention outside with minimal contrast approach. So we put in impellers. We doing a EBU 375 guide to the left side. We try to use the AL1 guide through the right radial, but because of lots of interactions together with impeller, we can only able to manage to engage JR35 to some French. So we quickly do some integrate preparation with a lower tip polymer jacket guide wire, XDA in this case. I try to go as far as possible, and then I quickly go to the retrograde PCI. So I tried to serve the first septal first, no contrast, and then it didn't really go smoothly, and then I used another septal branch, which by septal surfing using 003, we can go to the distal PDA. So this is important using a low-dose contrast PCI is there's certain key steps you need to inject contrast for safety issues. And this is one of them for CTO retrograde PCI. We need to make sure the retrograde wire is going into vessel architecture, not go to any funny space like the ring structure, because the next step I'm going to push my retrograde market into the distal PDA segments. Then I changed the 003 wires using, try to stay within the vessel architecture. This is the intermediate penetration polymer jacket guide wire, the Galactic EX. It goes smoothly follow the integrate guide wire. And then subsequently, easily, quickly, I can do the guide liner reverse cut in order to externalize my retrograde gear. And in this particular case, I will still try to externalize because the inadequate support from the integrate guidings. So the next will be ballooning, lesion preparations, and still not much contrast has been given. And IVUS is essential to try to land the right spot. The talks by Dr. Liew is very important, but I think it's very important to case selection to use DCB. In this particular case, CKD, minimal contrast, probably we may be able to tell whether the good lesion preparation achieved, and then we cannot give a lot of contrast to confirm whether it's a bad dissection or not. So probably, and the sizing is reasonable, I try to still stick on stand in this particular case. So this is the landmark. So I'm putting a long stand. It's a big size, 3.0 and then 4 by 3.5. So this is the final shot over the right side, the second shot over the case, and you can see the angiographic result as well as the IVUS findings. So it's important to see how is the donor artery, whether it's perfect or not. So it's another essential shot where I need to give contrast. So up till now, I think I only give puff around 12 cc only. So the patient is remain very stable, so we go ahead for the left side. To limit the contrast, I need to visualize more adequately the LAD CTO morphology, and this is what I did, the tip injection to clearly see. In fact, it's not really a tough CTO. It's calcified, it's short, and it's straight. Of course, there's no retrograde option for this case, so I tried to really floppy wire, and over my surprise, even the Xeon wire can go through the LED subtotal LED lesions. But here come with the uncrossable lesion. That's the last bit I mentioned about. We use the smallest balloon, 10.108. We also use the BAM techniques, different metal catheters, toggable, non-toggables, and even a guide extension catheters using a 1 balloon to further cross, which we failed. So I tried to illustrate with a stent booth here. Actually, this is the kissing calcification over the mid-LED segments. If you follow the same balloon-uncrossable approach, which mentioned by the last speaker, we already go through the first stage. So we need to use the second stage strategies. And in this particular case, I need to use lasers to cross because no microcatheters can cross. So there's no motivation for us. So I need to use the laser to modify the very calcified lesions. And you can see the laser actually is a 0.9 smallest laser catheters. In order to modify the calcified lesions. And then subsequently, be able to modify the lesion, and then I'm able to cross with a microcatheter. So the microcatheter cross, and you need to understand laser is not just for you to cross the lesion, but it's for to help you to modify the very calcified lesion, and subsequently we use the rotation to chip. This is another shot I need to test because I'm doing a lot of work on the LED. I'm not sure whether I can still rotate or not, but you can see there's still a bad calcified ring in the distal portion of the mid-LED. So I need to go to 125 rotation to here to pass through the last bit of calcified lesion here. So you can see that even the 125 cannot cross. So these kinds of laser facilitated subsequent rotation is, I think, is the most breakthrough, I think, in the uncrossable lesions. So I did lesion preparations, again, 204 by 25, try to visualize by imaging. You can see there's lots of dissections, very calcified in the mid-LED portion. There may be a certain short portion of the wire likely to be in the subminimal plane. probably because of the loss of dissections. So I think if it's not in a outer low dose contrast case, I'll try to use DCB in some of the portions. But in this case, I need to resort into a DES approach. So for the scoring balloon lesion preparations all along, and then this is the schematic diagram over the IFAS from the distal all the way to the proximal. So this is again, and we confess that this may not be the best approach, but in this particular case, we know to save contrast, and together with very badly dissected calcified case, so probably DS may be the only choice for me. So again, in the time, one is short, so circumflex is simple, just IFAS guiding. It's not a CTO, it's not calcified. Again, it's long diffuse disease. Prep the circumflex with a NC balloon subsequent for a scoring balloon. And then this is the IFAS still image from the ostium all the way to the distal. So it's a true bifurcation, 1-1-1 left-wing lesions. So we need to resort to a complex stentings. And I prepared the lesion with a 2530 subject from a stentings, and then all the way, no contrast at all still. You do a DK crush with a 30 and then 35 stents. So this is the final stentings, port, kissing, rewire, second kiss, and then final pop. And this is the final angiogram after the whole procedure. So, so I think the only regret is the stent is long. I meet it probably in another case. If we are not doing a ultra low dose, we can able to save some contrast, or you can able to give more contrast to delineate exact anatomy to do some DCB in certain segments. And this is the final shot of the LAD. So I think this is the best we can do for him, for her. So the IFAS imaging so good lesion expansions as well as the positions. I think for certain cases, you really need to highlight the limitation of the using contrast. And in this particular case, it's a long procedure. It's almost even up to 5-hour procedure. We could 30 cc contrast. We're able to win off the impella on table, close the wound because the patient remained very stable despite we complete revascularize. The wound was closed with a 14 fragmenters, and the renal function remained static, able to discharge the patient 3 days later. And actually, patient up to now almost 6 months remained well. Last follow-up in clinic in 1 month ago. So I think, ladies and gentlemen, in order to conclude, careful planning of a cheap PCI, especially in patients with CKD, is essential. We need to know the techniques you have, the equipment available. Minimal contrast is feasible in selected cases, not all cases, I think. In selected complex PCI case, including CTO interventions. We have discussed about the treatment algorithm, including uncrossable calcified CTO lesion, echo with the last speakers. And in particular, in this sort of cheap patient, complete revascularization have been shown to be a better outcome. So we try to achieve complete revascularization within the limited resource, financial, as well at the time. So thank you very much.
Alan, you did very well for your patient. I don't know about your limited resources. I would think that I would have limited resources. But you know, the procedure itself is long because of the complexity. But once you use ultra low contrast and you're basing only for imaging, that would also add on to the time, I'm sure. Any comments from anyone? No comments on that side?
Yes. I think sometimes even for a complex CTO procedure, I think it may be up to 2 to 3 hours. So I think we from the original imaging, we think that outside can be tackled with this low dose approach. Because I think it's feasible because retrograde actually helps you save a lot of contrast. I asked you how can you use it? Only 30 milliliters of contrast. You see, I think no. We need to the trick is you need to keep the contrast at the essential moment, right? Even after the retrograde piece, I think I have shown you the key moment. The key moment is after retrograde rhyme, you need to make sure the right spot. After, the finishing shot is so-called the legal shot, as for some of us. Sometimes even you can skip that, but of course you cannot check for perforations. The patient with hemodynamic remains very stable, even we do the lasers as well as the rotational fractomies. So I think if anything happens, the patient becomes ischemia, you have EKG change, you have hypotension, despite the MCS support, then you need to give contrast. Otherwise, I think it is still very safe to go ahead without. Yes, yeah, I think I've discussed about at the beginning. So if the patient is rich enough to consume 2 impeller for her, then I will separate into 2. But cost is always a limit. This is a very important concern, I think, for all of us.
I think you have definitely more experience than us, but we have got a small number of cases that we've done in impella. That one of the things we learned is that the longer the procedure is, the higher that risk related to the procedure and impella. So we tend we tend to use impella just to do the important sites first, and then we stage. But because when you come to stage, then patient is more stable, and we find because otherwise the risk of bleeding and so on is much higher. So and that is something that we have taken on in our institution in the sense that we only do ones that we think should be done, and then we stage them later purely for safety reasons. That's it. But you've got more experiences. So Alan, thank you very much. So I would like to thank all the panelists and of course my co-chair and the presenters, because we learn from cases, and hopefully this will, you remember all the cases presented and how you can learn from it, and hopefully it will improve in your own practice. So thank you very much, and enjoy the whole day.